Welcome back to Oncology for the Inquisitive Mind. This is our 201st official episode, but in total we've done about 216. So that means Michael has had to hang out with me 216 extra times on top of what we have done in the past. I'm, as always, accompanied by my glorious co-host, who is still wearing his bull white t-shirt, and I'm wearing a doggy white t-shirt. So it's great to see you. Michael, how are you today?
It's great to see you too, Josh. And yes, the handcuffs are still intact for the forced interaction. I kid, of course.
He doesn't.
I don't. I'm blinking multiple times for you. For those of you watching YouTube, please send help. But no, we're having a great time on this show, and we are. That sounded so
doing
insincere.
gastric cancer.
I'm so sorry. That sounded so insincere.
It's so passive. I love it.
That's my default form of aggression, is the passive form. But yes, today we're continuing on our Gastric and GOJ journey, and we are advancing, as I said, because I am not at all good at puns, we're advancing into the advanced setting.
It was terrible.
It was terrible. It was terrible last week when I said it, and it's terrible again today. But hey, I have no imagination. So I'm going to say the same bad puns again and again. But yes, we're going to talk about some advanced and metastatic gastric cancer. And Josh, because I am a benevolent pseudo-dictator, I was going to say a benevolent dictator, but like a bad dictator. Like I wouldn't be good as a dictator.
There are no good dictators, my friend.
I mean, like effective as opposed to morally good. So
there's probably lots of effective. There's probably a lot of effective dictators. They probably think they're very good at what they do.
That's my point. Is that I would not be one of them. But what we're trying to say is that I have let Josh have the interesting study for 2 weeks in a row because I am benevolent. I am benevolent and good, but not efficient. I think that summarizes my.
Let's
character.
Just start.
Josh is tired of me now. So yes, the study that I'm going to be talking about is the old faithful in the advanced gastric and GOJ setting. It is Checkmate 649. Fear not, there will be a brief mention of Checkmate 648, which was sort of a twin study for squamous cell advanced gastric and esophageal cancer. There'll also be a mention of the Attraction 4 study. So even though I am getting the quote-unquote less good study, I'm using that opportunity to cram 3 studies in for the price of 1, because that's the kind of value we bring to you on this podcast. For the background, so 5-FU-based doublet chemotherapy is, or I should say was, the standard of care for patients with metastatic upper GI adenocarcinoma. And it was until pretty recently, this study is not that old, Josh. And at the time of publication, the median overall survival for patients with advanced cancer on this regimen was still about 12 months. So it comes back to some of what we mentioned last time with FLOT4 and Matterhorn, that even though we are making incremental evidence, the outcomes are still inadequate, shall we say. Nivolumab, which is a PD-L1 inhibitor, as everyone and their dog knows. And if you want to hear more about dogs, you should listen to the last episode, which had a cameo from my dog Beans deciding to try and destroy my desk. But even he knows that nivolumab is a PD-L1 inhibitor, and even he knows that it demonstrated efficacy in heavily pre-treated patients in the Attraction 2 study. The question that Checkmate 649 aimed to answer is whether there was benefit in the first-line untreated cohort. So Checkmate 649 is a randomized control trial of almost 1,600 patients, 1,581. Patients were randomized to receive standard chemotherapy versus chemotherapy plus Nivo. And for those of you who are practicing or who have looked deep into this study, you will also know that there was an Ipi-Nivo arm in this study. We're not going to talk about it too much, and we'll come to the reasons why, but generally speaking, Ipi-Nivo is not used in this setting, though that might change in Australia given the widening or the broadening of indications for Ipi-Nivo. Patients had to have previously untreated locally advanced or metastatic adenocarcinoma of the esophagus, the gastric esophageal junction, or the stomach. There had to be ECOG performance status of 0 to 1 with measurable disease. And patients who had previous neo or neoadjuvant treatment or perioperative treatment were allowed as long as it was greater than 6 months prior to randomization. Patients with known CNS disease were excluded, and that's not something that you see a lot of in gastric cancer, but I have seen a couple of cases. It never ends well. And the other critical thing, and this will be important for Josh's study, is that patients with HER2 positive disease were also excluded. So take that, Josh, you'll be able to tell me, but 15% of patients thereabouts who are HER2 positive with gastric cancer, and throw them in the bin because they're not relevant for this study. Now, there was a bit of toing and froing of the primary population that was put under analysis, and eventually they settled on the patients who had a PD-L1 CPS, that's combined proportion score, of 5 or more. The dual primary endpoints were overall survival and progression-free survival, and the secondary endpoints were overall survival in patients with a CPS of greater than 1, the intention to treat population, regardless of CPS score, health-related quality of life, and safety. A couple of demographic notes. Again, similar to the FLOT4 study I presented last week, the majority of patients, 70%, were men. The majority were ECOG 1, which I thought was interesting, 60%, as opposed to ECOG 0. And 70% of patients had gastric cancer. Only 18% had GOJ and 12% had esophageal. So if you want to be a strict statistics person, then the applicability of this study to GOJ and esophageal cancer could reasonably be called into question. If it is, but it's not practically called into question because this is a catch-all regimen that we use in modern practice. The majority of patients were metastatic as opposed to locally advanced. And I think with the advent of perioperative chemotherapy, the incidence of patients with cancers that are just so big that they can't be resected but are non-metastatic otherwise has greatly reduced. So in terms of the results, so the primary endpoints were met. The overall survival median was 14.4 compared to 11 months in the patients with a CPS of greater than 5, and this had a hazard ratio of 0.71, and it was statistically significant. The overall survival for patients with a CPS of greater than 1 was 0.77, the hazard ratio obviously, and the progression-free survival was 77.7 compared to 6 months with a hazard ratio of 0.68. The 12-month PFS estimate was 36%. Now, so far in this episode, if you're a long-time listener, you haven't gotten very much more than what was said in a previous episode that we looked at this study, because like I said, this is not the first time we've looked at this study. It has been around for a little while. However, because we like to keep things fresh and keep you coming back for more, I'm delighted to report the 5-year outcomes for Checkmate 649, which were only released in 2026, which at time of recording was this year. The overall survival was broadly consistent with the initial analysis, hazard ratio of 0.71. The PFS was 7.7 months in the treatment arm compared to 6.9 months in the control arm, so a little bit better in the control aspect. They also included PFS2 data, which we do love. The PFS2 was 12.2 compared to 10.4 months. And we come to probably the grimmest reading of all, is that the survival rates, or I should say the 5-year survival rates, were 10% with FOLFOX-NIVO compared to 6% with FOLFOX alone. Survival rates were maintained regardless of CPS score, and there was superiority demonstrated in overall response rate and duration of response, and there was no new signals with regard to adverse events. FOLFOX and NIVO are treatments that we've had for a long time, and there wasn't anything particularly new or interesting there. So what did Checkmate 649 tell us? Well, it showed us the chemo plus NIVO is superior to chemo by itself, but we still need better agents. A median overall survival of 14 months is really, I don't want to say not good enough because, this is the best that we have, but we want it to be better. I do want to make a quick, dirty comparison to Attraction 4, which was published a year after Checkmate 649. This was a phase 2 to 3 trial in Japan, South Korea, and Taiwan that compared chemotherapy with SOX, which is S1 oxaliplatin, which is I think it's a 5-FU derivative or similar to 5-FU that we don't have in Australia, but is commonly used in Asian and Southeast Asian countries, or CAPOX, with or without nivolumab. It was placebo-controlled. And the outcomes were similar, but slightly better, shall we say, in terms of PFS, if we're comparing it to Checkmate 649, 10 months as opposed to 7 months, and an overall survival of 17 months compared to 14 months. However, what's interesting is the placebo arm had a very similar overall survival. So with Nivo, 17.45 months, without Nivo, 17.15 months. And practically speaking, that's what, Josh, a week benefit on average, something like that? So another example as to why dirty comparisons are not the best, because, there's probably any number of reasons why the control arm overperformed, you would say. Also, a quick note on the Ipi-Nivo arm. This did not show an overall survival benefit that was statistically significant, and it had a significantly higher toxicity rates than chemotherapy by itself. So we don't use Ipi-Nivo in this space, but we might when we're desperate. And a final note on my final study, because I've really crammed it into a short time today, on Checkmate 648, which again showed the superiority of nivolumab plus chemo in esophageal SCC. There was a greater magnitude of benefit compared to the adenocarcinoma space, which again you could sort of expect because stereotypically squamous cell carcinomas are more immunosensitive than adenocarcinomas. And what was interesting, considering that these studies came out at similar times and, one number difference in terms of their titles, 648 and 649, they used TPS, which is tumor proportion score, instead of CPS to stratify patients. And I think just to illustrate the difference that can make in jumping back to Checkmate 649, sorry, this is the last thing I'll say, Josh, because I know you're aching to get to your study, which I won't spoil it in advance, but concerns a certain ADC that we are fans of. But the PD-L1 TPS for patients in Checkmate 649 was less than 1% in 75% of the patients who had a CPS score of 5 or more. So just because you have a low TPS doesn't necessarily mean you have a high CPS, obviously, because the CPS includes immune cells as well as tumor cells, hence TPS versus CPS. So it means that the quantification scores are difficult to compare, which I think we've mentioned before. But yeah, FOLFOX-Nivo, it's what we got. But Josh, is there anything else on the horizon? What is our destiny in this space?
That was a whirlwind, and yeah, it's such a difficult space because there are those people who will still respond quite well to the Checkmate 648, 649 stuff, irrespective of their TPS and irrespective of their CPS, and it's just this like that tail end that you sort of crave to grow, right? It's sort of, but you mentioned a couple of things when you started your beautiful rendition of those trials, which was like HER2 was excluded because HER2 is it's a target, right? And in most cases and most cancers, if you've got a targetable agent, you'll probably go there first. Just sort of the summary. And the standard of care when these trials came out was you went to chemotherapy and trastuzumab as a first line. Well, let's talk about the background because I'm a background fan because depending where you live or where you work, your patients want to know how many people, what's the evidence, what's the numbers, what's the data, right? We know about 15 to 20% of advanced gastric and gastroesophageal cancers have overexpression or amplification of HER2. The standard of care was an anti-HER2 antibody, trastuzumab or Herceptin, plus chemotherapy. Right? This was based on the TOGA trial, which is trastuzumab for gastric cancer. Don't know where the O came from, but it was called
It's the middle letter in 4, Josh, obviously.
Obviously, I'm like...
And what would it be? Tafga is much less catchy.
That's it. I was looking at this being like, there should be something more, I'm pretty blunt, but I'm a blunt instrument, but I should have been able to pick that up. Either way, so first chemotherapy alone, they found that overall survival was longer, not great. So 13.8 months versus 11.1 months. Then next line of ramucirumab and paclitaxel. Ramucirumab is the anti-VEGF-R2 inhibitor. For those who have not used ramucirumab in Australia, it is not PBS listed. I was having a look at this. It was PBAC approved, but then there was some argy-bargy about costings, and so it never came to market. There are lots of really big numbers in this little document I read, and I wasn't sure how to interpret it, but that's probably why it's not here at the moment. But in the second line, ramucirumab plus paclitaxel had a median overall survival of 9.6 months versus 7.4 months with paclitaxel alone, and progression-free survival was 4.4 versus 2.9 months. Like neither of these they're not resoundingly exciting numbers. Other lines of therapy you can think about is irinotecan, taxane, Lonsurf, immunotherapy as well in this cohort of patients, or send them to trial. The drug we're talking about, like all the drugs we talk about, is trastuzumab deruxtecan, which is like pembrolizumab. It's everywhere.
Yes, all drugs are trastuzumab deruxtecan now.
All
Even
drugs.
the ones that aren't. We are all Spartacus.
Yeah, that's it. But trastuzumab deruxtecan, not Spartacus. It's a cytotoxic topoisomerase 1 inhibitor with a cleavable tetrapeptide based linker. There have been earlier studies of showing pretty interesting evidence with regards to that, and objective response rates of about 40%, with a median duration of response of 7 months and a median progression-free survival of about 5.6 months. And interesting, given that the payload is a irinotecan derivative, topoisomerase 1 inhibitor, they still had a good response rate. So this was a phase 2 study, Michael, not a phase 3, but a phase 2. And I think that's something that I wanted to start with. It's not a massive study, and I'll get to exactly sort of what the future of this trial looks like.
But Josh, what phase study was it?
Phase 2. Thanks, man.
You just said it with such emphasis. I felt like it needed to be said one more time.
Well, I was sort of expecting them to kind of go to like this big phase 3 when I looked at the numbers, and then it sort of we'll talk about it. So it was a phase 2 trial. It was a late line trial. You had to have at least 2 prior lines of therapy, including fluorouracil, platinum agent, and everyone had to have trastuzumab. A HER2 level was required. There either had to be a HER2 3+ on immunohistochemistry or HER2 2+ with FISH or in situ hybridization being approved. They were randomized 2-1 to TDXD versus physician's treatment choice of chemotherapy being irinotecan or paclitaxel. The primary endpoint in this study was objective response rate. For those that are here with us on YouTube and have given us 5 stars and a comment, you can see the result of that, but I will get to it in a minute. And then the secondary endpoints are overall survival, duration of response, progression-free survival, and then they had a central analysis of disease control rate, objective response rates, and safety. Looking at demographic notes, because I think that's important. 188 patients. It was predominantly an Asian study, so from Japan and South Korea. 125 had trastuzumab deruxtecan. 62 patients had treatment of physician choice. Median prior exposure was 2 drugs. Maximum 9. Whoever had 9 and still going, like incredible.
A lot of trials and a lot of re-challenges, I think.
That's it. 70% had at least 4 prior therapies, and 70% had prior ramucirumab, and 86% had prior taxane. Now to like the juicy part, or the results. Should just say results. Objective response rate was 51% versus 14%. Confirmed objective response rate through a central analysis was 43 versus 12% with the scan about a month later. And about 10 patients of the 119 had a complete response in trastuzumab deruxtecan's arm versus 0 patients in the standard of care arm. More than 80%, as you can see these waterfall plots to the right of the screen, the top being TDXD, the bottom being paclitaxel or irinotecan. You can see there's a stronger signal when it comes to tumor reduction. So 80% had a tumor reduction versus 50% in the standard of care arm. The median duration of response was 11 versus 3 months, and the time to response was similar, about 1.5 to 1.6 months. Disease control rate was 20% better in the trastuzumab deruxtecan, and the overall survival was significantly longer in TDXVD versus treatment physician choice of 12.5 versus 8.4 months, with a hazard ratio of 0.59. What I also noted is that 62 patients had died in the TDXD arm and 39 in the treatment of physician choice. So about 50% of the trial arm and 63% of the control arm. At the 12-month mark, the difference of who was alive, 66 versus 52, favoring trastuzumab deruxtecan, and 48% in TDXD had a subsequent treatment, and 50 or 70 something in the standard of care arm. When you look at the Kaplan-Meier curves, you can see there is quite a significant breakaway for overall survival and progression-free survival as well. So median progression-free survival at the 12-month mark, so about 30% were disease-free or hadn't had progression at 12 months, and no one in the treatment physician choice had not had disease progression at that 12-month mark, with the average median progression being 5.6 versus 3.5 months. Then, of course, moving to toxicity, because toxicity is key when we do this stuff. But toxicity shows that you get the as expected of ADC being that of nausea, which is always pretty severe. We can manage it, but not grade, a lot of grade 3, neutrophil count, appetite, malaise, diarrhea. Always have to look for things like pneumonitis, which is generally about 9 to 11%, although they haven't mentioned that when you look at the most common, but that's something that's very important and requires HRCTs on a regular basis. And that's really, really my trial in a nutshell, Michael. There are a couple of things to chat about. Look, this is all like, oh yeah, these numbers are really exciting for that cohort of patients. And you're like, why haven't you just gone to a phase 3 trial? Well, first of all, cohort of patients were predominantly of Asian descent. And yes, that's where there's a very high incident of gastric and GOJ cancers, but there was no other. So it's very monocultural. So that's the first issue. The second issue being a limited sample size, not huge. The second issue is the heterogeneity. So I think when I was reading up on this trial, I don't think they had to have a new biopsy. I think it was based on existing HER2 status. So many cancers, things can change, including expression and amplification, and even those have influences when it comes to how people respond. There was concordance in about 64% from a post-analysis for ctDNA for HER2 positivity and plasma gene amplification. And then there was also signs of resistance. So people that had MET mutations, EGFR, FGFR2, they didn't respond as well because there's other pathways at play here. Of those who had a gain of function HER2 mutation, the objective response rate was nearly 60%. Really interesting stuff. So this was published in 2020, and I'm like, where's my phase 3, mate? Give me a phase 3. Couldn't find it. But what I did find is there was a Destiny Gastric 02, which is based in USA and Europe, which is a single arm with the key endpoints points again being objective response rate. And they found an ORR of about 38% and a partial response in 37% of patients. So they've obviously expanded it into a Western market, I guess you would say. And then we've got Destiny Gastric 03, which I forget. It was something of interest. And then we've got Destiny Gastric 04, which is putting it head to head of ramucirumab and paclitaxel. So this is, I think, a second line treatment in patients who progress through a trastuzumab and chemotherapy based regimen. So this will be the really interesting crux. So the summary from all those numbers and all that data is that second or third line, I think you should use this. I think there is enough evidence to say that if you've got it available, then it would be a good addition to a treatment option for these patients. What we don't know is if you move it up the lines, is it going to be better than this current standard of care? Because there is a lot of sort of heterogeneity and unknowns when it comes to even immunohistochemistry being used as kind of our marker for HER2 expression and then correlation with response. So there's a lot of space. It's not like the breast cancer space or other cancer types. It's different and unique.
Josh, you took the words right out of my mouth on multiple occasions with your little summary there. But yeah, I think
thank you.
The difference between HER2 mutation and amplification, and we've mentioned this, I think, with our lung cancer episodes as well, and also, the difference between overexpression and mutation is much more important in non-breast cancers than it is in breast cancer. And so I think it's really interesting that TDXD, because one of the things I was taught is that if you have a mutation, trastuzumab frequently doesn't work because it works by binding the overexpression of HER2. But clearly, if you add a payload to it, TDXD, then it overcomes that limitation if you have an overall response rate of 60%. I think your point about rebiopsying is also very interesting. Extrapolating from breast cancer, I know we just said not to do that, but extrapolating from breast cancer, we see that people lose their their HER2 positivity when they are heavily pretreated. And so it is interesting that is, that is not something that was mandated in the Destiny Gastric 01 study. But I will be looking forward to Gastric 04 with bated breath.
That's it. And hopefully it'll read out in the next year or two. And when we update this on our 200 millionth episode, we'll be able to give you a bit more data what should be a second-line therapy.
In my day, we used this thing called chemotherapy.
We had social media and it was terrible.
No one cared who I was until I put on the mask. I won't get old. I'll just turn into Bane, is what I'm saying. Anyway, shall we wrap this episode up, Josh?
Michael, I think we should. But look, it was a good episode. It's really interesting space, the gastric. I feel it never really gets the limelight, but that might change.
It might change. And one thing that we didn't talk about, which we will almost certainly in the future, is the emergence of the anti-claudin inhibitors. I think it's zolbetuximab or one of those ones, because that is an emerging space that is very interesting. But I think that deserves its own episode.
100%.
So next episode, we are moving away from the stomach and into the pancreas. We're sliding down that alimentary tract. Pancreatic cancer, of course, one of the few cancers that are worse in terms of outcomes on average than gastric cancer. And so we'll be talking about the minority of patients who are diagnosed early and what to do when you're confronted with such a patient and such a disease. So we hope to catch you then. Josh, as always, thank you so much.
And thank you. And Michael, just before we go, the iconic Magic School Bus, which I feel like we're doing at the moment, the quote from Miss Frizzle is, take chances, make mistakes,
get messy. Yes, we should use that as well. Take care.
Bye.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.